Good morning, all, or good evening, depending on where you are in the world. Firstly, our thanks to the International Continence Society for the opportunity that we've been provided with to present to you on this topic about incontinence and continence care in nursing homes, what we can learn from the social sciences. My name is Dr. Joan Ostashkiewicz, and I'm a long-standing member of the International Continence Society, and I'm a registered nurse. I direct a program of research at the National Ageing Research Institute in Melbourne, Australia, and my main area of research is about the management of incontinence in nursing homes. And the main question that's really driven me all these years is what care is provided in nursing homes and why? And this question has meant that I've dipped my toe into the social sciences, and really I'm very humbled about the huge body of research that's there, and take my hat off to the sociologists, psychologists and anthropologists. But there are many learnings for us. With me tonight is my colleague Dr. Tina Vaitinen, and I'm sure I've said that wrong, Tina, but she's a good colleague of mine. And a postdoctoral research fellow from Tampere University in Finland. Our paths crossed at the ICS scientific meeting in Gothenburg last year, where we realised we shared research interest in issues related to continence caregiving. Dr. Vaitinen is a political economist and a global health scholar, and she brings fresh new insights to the issue of incontinence and continence care in nursing homes, and I'm delighted that she agreed to join me to tackle this topic.
So thank you, Joan, for the introductions, and I'm really delighted that you asked me to join this talk, and quite excited. I will tell more about my own interests in a bit, but before I let Joan to start our presentation, I'm gonna tell you about the opportunity to comment and join the discussion as well. We do want to hear both comments and questions about what we are going to be talking about today. And there is below you have the talk now showing on your screens, and below there is a title comment. If you tap that, there is a possibility to send us comments. I will look these comments through on my mobile phone while Joan is speaking, and then we will get back to some of the comments, questions already before Joan hands the turn, and then also at the end. And thanks again for joining us. I'm really looking forward to today's discussions.
Thank you, Tina. So let me start. So Tina and I decided that really we can't talk about continence care in nursing homes without really giving some context about the nursing home environment. So we're going to introduce some information about our nursing home environments in our respective countries. And we're going to present what we call the context of continence caregiving in nursing homes. And the context we're going to cover relates to constraints to caregiving and the skilled, the demanding, the virtuous, undervalued, underpaid, gendered, racialized, classed, and stigmatized nature of continence caregiving in nursing homes. We'll share with you some findings from the qualitative research that each of us have individually conducted on continence caregiving in nursing homes. And given the context, we will raise the question further in the presentation about what knowledge, skills, and attributes are required to care for nursing home residents with continence care needs. And finally, we'll debate the merit and drawbacks of using the guiding principles of choice and dignity in an ethic of care for older people who require continence care in nursing homes. So let me start with nursing homes in my country. In Australia, there are 2,722 nursing homes provided by 845 providers. We call them residential aged care facilities, but for the purposes of this presentation, I refer to them as nursing homes. 41% of these homes are for profit. 55 are not for profit, and 4% are government. In the last year, the cost to the Australian taxpayer of providing nursing home care was $13.4 billion. Just under 1/5 of the 25 million people who live in Australian nursing homes are women. The average length of stay is 2.5 years. Most are over 85 years of age. There are some young people in our nursing homes, about 6,000 in total, and they range between 20 and 65. 1 in 3 of our aged care residents are born overseas. And as you can see here, 50% experience a fall within a 12-month period. But that's only part of the story. Rates of incontinence are high. 77% of residents in our facilities have urinary incontinence 3 times a day or more. 34% experience 5 episodes or more of fecal incontinence a week, and 73% have a toileting disability. And there are high rates of antipsychotic use, opioids, and sedatives. To me, the most compelling data here is that 50% of residents have a diagnosis of dementia. It's actually probably much higher than that, but that's the diagnosed cases. Why is this compelling, you ask? Well, it's compelling because what we know from the social sciences is that incontinence within the setting of a dementing illness like dementia invariably bears no comparison with that of people who don't have dementia. This was a phenomenological study conducted back in 2005 by Upton and Reid, and they interviewed family caregivers of people living with dementia in their own homes, and they found that incontinence presented as a behavioural problem that was physically and psychologically draining for the caregiver, especially when there were other challenging behaviours present. Another thing that makes continence caregiving complicated, particularly in the context of dementia, is that caregivers have no choice but to what's called grapple with the problem. And this is what, these are not my terms, it's actually Upton and Reid who said this, that it's not a condition like a wound that you can perhaps leave for an hour. It's something that you have to take immediate responsibility for if ongoing coping is to be sustained. And so it's probably for that reason that people who can't grapple with it find that they have to relinquish caregiving roles. Another compelling statistic of from our Australian nursing homes is that 23% of nursing home residents die within 12 months of admission. And for me, this raises questions about the appropriateness of our current guidelines and recommendations for the management of incontinence, because they're predicated on the goal of cure or symptom improvement. With the admirable exception of work conducted by our UK and Canadian colleagues, Professor Mandy Fader, Professor Adrian Wagg, Dr. Kathy Murphy and Dr. Naomi Farrington, there's almost no empirical research about end-of-life continence care. However, we do know a lot about end-of-life symptom management for other things like pain, depression, confusion, dyspnea, fatigue, anorexia, vomiting, and even constipation, but actually nothing about incontinence. And so end-of-life continence care is likely to be based on routines and traditions rather than evidence. In fact, there was a review of guidelines about palliative care done some years ago by Farrington et al., and Farrington claimed that it's an area of nursing practice governed by common sense and precedent rather than evidence-based practice, and particularly practices relating to the use of indwelling catheters. This is concerning because if there's a lack of evidence, it means that there'll be uncertainty in practice and inconsistent management, and it could result in the under or over treatment of bladder or bowel symptoms, including the under or overuse of catheters. Another important context in nursing homes is the workforce that we rely on to provide continence care. In my country, there are 235,000 people who work in nursing homes, and 70% of these are personal care assistants, who typically undertake a 6-month part-time course. They're what we call unlicensed workers, and their role is to carry out non-complex components of personal care, ostensibly under the supervision of a registered nurse. The quality of their training is highly variable and doesn't equip them with the complex skills involved to meet the complex care needs of vulnerable Australians. 15% of the workforce are registered nurses, and most of them are in managerial roles, and they have overall accountability and responsibility for the quality of care. And 10% are enrolled nurses who typically undertake a 2-year course and who work under the direct or indirect supervision of a registered nurse. Another important factor here is that 32% of this workforce were born overseas, and some of them are on temporary visas. I don't know what it's like in your country, but our people on temporary visas in our country can work, but it does make them a vulnerable workforce. A PhD study conducted in New Zealand suggests that being on a temporary visa can generate a situation in which the personal care assistant extends their role into the domain of the registered nurses in order to protect their job because of the employer's expectations and because of a gap in RN expertise. So all of these factors collectively make for a culturally and socioeconomically vulnerable workforce. They're comprised mostly of women. They're usually underpaid, under-recognised, and powerless to alter the conditions of their work. And that we as a society rely on their altruism. There's evidence to suggest they experience poor working conditions, heavy workloads, occupational health and safety concerns, insufficient training, lack of training, constant administrative demands, and comparative low remuneration. And now I will hand over to Tina.
Yes, just a couple of slides on the context of nursing home residents and nursing homes in Finland. I don't have exactly the comparative figures to compare to Joan's presentation, but partly because I can find similar kind of figures, and obviously because the systems are different, but also because I do want to draw attention to some of the structural questions that actually are at place very much also in Australia, in the UK, and a lot of the so-called Western societies when it comes to nursing homes and the markets for nursing homes. But to start up with, we are a population of 5.5 million in Finland, and the most recent figures for the numbers of nursing home residents in Finland are that in 2019 there were a total about 45,000 residents living in nursing homes. With the term nursing home here, I refer to what we call in Finland intensive service housing. So it's a 24/7 serviced housing. They hire their rooms, so they pay rent for their rooms, and on the top of that, they pay for the care that they receive. This system has changed over the past year. So it used to be sort of what's in Finnish called institutionalized care. In the sense that, more or less, there would have been shared rooms, for instance, not necessarily toilets in every single rooms and things like this. So privacy has increased with the new system, but at the same time, the payment system has changed. So whereas in the previous system, the residents paid for one lump sum that covered their housing and the care that they receive, in the new system, they pay for the rent and then they pay for the care services separately. So there are like economic changes included in this more home-like living. And what has also changed over the past few years, and that's the trend at the moment, that there is a policy trend that we want older people to age at place, meaning at their own homes. This also means that the threshold of getting a place in a 24/7 nursing home has increased. And it means that we have more and more older people living in their own homes at conditions where previously they would have been accepted in a 24/7 nursing home. So while we talk about nursing home, we also need to bear in mind that sometimes even less, and actually not sometimes, less staffing and less resources and equally weak care recipients live in their own homes and rely on nursing and community care. So many of these things that we speak about today actually also can be applied to old age care provided to people's own homes. But anyway, as Joan also mentioned, I think, or it will become later, so a majority of the residents living in nursing homes are women. So about 7 out of 10 residents in nursing homes are women. That has to do with with the kind of share of reproductive labor and care labor that we have in most of societies. That obviously, if the male grows older, gets weaker, the wife tends to take care of them. But when it's on the other way around, then there is a better chance for the women to get a place in the nursing homes, because the men might not be able to provide that care, or it's considered that they are able to provide that care. That said, on the top of this professional care provided in nursing homes and by nurses to homes, we also have a lot of really quite weak older people taking care of their spouses. So a lot of the things that we talk about today, we also have to bear in mind that much of this work is actually done by family members, spouses, daughters, other relatives, and so on. And then other figures, hold on. Oh yeah, change slides, please. Is compared to nursing homes versus community care. Oh, no, not yet, Joan. Can you put back that? Yeah, thank you. Yeah. So if you just only look at the staff versus client ratio in community care, where you can have also rather weak care recipients, there is only 1.3 nurses per care recipient, whereas in nursing homes, on average, you would have 1.7 nurses per care recipient. And also clients who there is an increase in people who are receiving services at home compared to less people every year living in nursing homes. So there is this trend is showing. So we have more and more people living at home and receiving services there with lesser staff resources than we have in nursing homes. And change the slides, please. Yes, and some figures when it comes to clients with dementia and community care. So about 1 in 5 of people who receive services to their homes live with dementia, and then about 50% also in Finland are diagnosed with dementia who live in nursing homes. But as Joan says, this is about diagnosed cases, so the actual figures are likely to be higher. And also these statistics are from 5 years ago. So again, the figures could have changed since then. And change slides, please. I could not find exactly the same numbers as Joan mentioned from Australia. But overall, I can tell that nursing in residential elder care in Finland is provided by 3 professional groups. So the absolutely biggest group of nurses working in residential elderly care in Finland is licensed practical nurses. So I think this would be something that compares to enrolled nurses in Australia, and to the professional group that has received 2 to 3 years of occupational training in nursing. It is a licensed so it's a secondary level training, whereas licensed registered nursing is a bachelor level training, and it is a 2 to 3 years education, and they have a lot of responsibilities internationally compared to other nurses working on the same level. But practical nurses is the biggest group, and then you usually have if you have one floor in a nursing home, you would have most of the workers would be practical nurses, and then you would have one licensed registered nurse usually per floor, responsible for different kinds of like more clinical tasks, as well as of the sort of basic fundamental care tasks. And licensed registered nurses are trained in universities of applied sciences, and it's a 4 to 3 years training. And then the third group, this is a new occupational category in Finland called nurses assistants. This is not a licensed profession. It's only 10 months training, and it is a training for what they call the most basic care tasks, including continence care. So this is considered as somehow low-skilled work, continence care that you provide in nursing homes. And as we will discuss today with Joan, this is not a matter of low-skilled work. It is not manual labor. It takes a lot of different kinds of skills that we need to learn more about. There have been scandals in Finland in nursing homes. Just a year ago in January was a big one, and after that we have had a change in there wasn't legislation determining the nurses per carers per resident ratio previously, the minimum standard, but there is a law now, and the minimum standard now is 1.4 carers per resident at minimum. As you saw previously in nursing homes, the average at the moment is 1.7. So it doesn't have to be the minimum, but this is what it has to be. And also what has changed that you can only count people who, in this ratio, you can only count people who are actually providing care. It doesn't mean that you count only licensed professionals, but you need to count in those people who provide care to the residents. So you can't put in people who clean the place or who provide the food or janitors and so on, because that was one of the problems that emerged in the scandals, that the nurses, the carers per resident ratio, on the paper they appeared fine, but then when they started to look like who's actually there, you would have people who are not actually doing the care work, or you would have had even like made up persons that weren't even working on the premises. So these are some of the issues, and obviously supervising this is quite challenging. Can I change slides, please? And why is it challenging? So first of all, a few words about the money flows when it comes to old age care in Finland and in many other Nordic countries at the moment. So although we have a really strong welfare state at place in Finland, we have a constitutional right to adequate care. But this doesn't mean that we wouldn't pay for it. So when you get a place in a nursing home, or when you get services to home, what happens is that the municipality pays for the service to either they produce the service themselves, the public sector, or they pay for the service for a private provider, and then the municipality sends a bill to the citizen. The bill is not the same amount that the municipality has paid to the provider, or what it pays for providing the service itself, but it is still quite costly. You have to have some money left from your monthly income after paying the service fees, but it's not an awful lot. So it's publicly subsidized care, and it is income adjusted, but it is not completely free. Secondly, in residential elderly care, there are 3 different kinds of providers. You have, or like roughly put, 3 different kinds of providers, or maybe 4. So first of all, you have public sector services. So the municipality provides the services itself. Secondly, you have for-profit providers. And thirdly, you have non-profit providers such as charities. And within the for-profit providers, you can have small companies providing the care, but then you also have large companies owned by transnational investors. And in Finland, about 20% of nursing home services are at present provided by these kinds of actors. So, and their share grows each year. They buy smaller companies, and there is a lot going on there. These corporations, they do make a really quite nice profit of old age care in Finland and in other Nordic countries, as well as in other countries across the world. Not obviously the same companies in each country, but they are effectively tax funded because the municipalities buy the services from these companies. So it is our tax money that is paid to the companies for them to provide the services, and they make profits out of it. But then the profits are distributed to the shareholders. And there is also financial engineering, different kinds of tax planning, etc., etc. So this has actually quite a heavy impact on public economies as well, and so on. So, and one of the things, I'm not going to go deep into this, but one of the things that we need to ask in these kinds of contexts is what happens to the quality of care under the logic of profit, markets, and financial engineering. And this actually does have an impact on how and in what kind of environment the nurses provide the care in care homes or at people's own homes. And before we started the presentation, Joan just mentioned that there is actually also quantitative evidence of staffing ratios, for instance, that they do have an impact on the quality of continence care. Yeah, and next slide, please. This is just an example of one of the big companies operating in Finland from their annual report in 2016. So whereas for policymakers, it's often the demographic trend of aging populations is considered as a bad thing. But for these companies, it's a positive demographic trend. And you can see there that in Europe, care is already in in Central Europe and in the UK, for instance, high share of services are already provided by private providers. But then in Nordic countries on the sort of darker green, you can see that there is a lot of space for growth. So this is just an example of the sort of structural context in which the care takes place. Okay, next slide. And I think it's over to Joan after.
Thank you, Tina. Okay, so we want to move on now to talk about the context of caregiving in nursing homes. And the first point I want to make is that the quality of continence care in nursing homes is part of a large problem of ageism and the overall care quality, and that you can't just single out continence care as one issue and look at it in isolation, that it needs to be looked at very broadly. And now on this slide, what you'll see is a whole lot of comments that are based on people giving witness to a Royal Commission. So last year there was a scandal in Australia, and it hit the public, and the public were outraged, and the public put a lot of pressure, and the media as well, onto the government, and the government relinquished and called a Royal Commission into the quality and safety of care in residential aged care facilities. And that commission, that has been going on now for 2 years. Now, the Commission have so far received almost 11,000 submissions. They've convened community forums around the country for people to bear witness to their experiences of the aged care system. And last year they released their interim report. I did just a word search trying to find transcripts related to toileting and incontinence and urine and faeces. And throughout the whole report are a lot of transcripts like this that suggests that we really do have a major problem around the quality of continence care. So the commissioners in their interim report concluded that as a nation, Australia had drifted into an ageist mindset that undervalued older people and limits their possibilities. And they actually said, left out of sight, out of mind, aged care services are floundering. They're fragmented, they're unsupported, they're underfunded. Yes, there are some admirable exceptions, but that are poorly managed. And all too often they're unsafe and seemingly uncaring. And they emphasise that this must change. Now, I don't really want to bag my country at all. These problems are not at all unique to my country. There are any number of reports and scandals in other countries. For instance, recent research from the US suggests that up to 60% of nursing home resident deaths result from unnatural causes, including, but not limited to, blunt force trauma, falls, choking, drug overdose, burns, suicide, and homicide. And that was a systematic review of death. So the thing is, these things happen with a lot of regularity, and we've had numerous reports into the quality of care broadly in nursing homes over many years now, and we continue to have these scandals and problems highlighting issues related to poor care quality. And it's interesting looking at how people respond to the scandals, because usually they disappear within a couple of days of being in the news. And typically what happens is that there's blame and shame on the individuals who deliver the care, the nurses and the carers. And one of the things I've noticed over the years is that in our own disciplinary area, nursing homes and nursing staff are often tarnished as being nihilistic with respect to the prevention and management of incontinence. And if we really want to change the quality of continence care, then I think as leaders in the field, we really need to understand the broader problems of care delivery. So, as I said, that's been something I've been interested in for many years. And so when I did my PhD, I did a grounded theory study, the aim of which was to describe and explain how residents' continence care needs were determined, delivered and communicated. And the findings led to the identification of a basic social problem that I called caring against the odds, as you can see here. And all these factors went into making up this basic social problem. And although staff aspired to provide good care, including good continence care, the odds were not in their favour. There were 4 categories that were important that emerged as having the most impact on staff's ability to perform their role and deliver care. And they were the fact that they were working in a highly regulated work environment that caused them to be risk adverse. And they encountered ethically challenging situations. Residents were highly dependent and they had multiple residents to look after, and there was a devalued role. I'm going to pick up on 2 issues from these findings only, and the first relates to what I called ethically challenging care work, and the second, so that's the ethically challenging nature of care work, and the second one is around stigmatised work. So the second major point of my presentation is that providing continence care in nursing homes presents ethical challenges for care staff. And there's a couple of reasons for this. One of the reasons is that staff have to prioritise among multiple residents and their multiple care needs. And so they find themselves in a situation where they're making ethically compromising decisions on an everyday basis. And this is beautifully captured, I think, with this comment from a staff member who said, you might be doing one person and you know that another person is dying to go to the toilet, but you can't leave that person. Now, of course, those of you who are more pragmatic will say, well, all they need to do is to be better at prioritising, or they need to work more efficiently and get a routine going. I have to say I've never met anybody who works more efficiently than nurses or care workers. Some years ago, in one of the healthcare networks that I worked for, they introduced lean thinking into an aged care facility. And I really thought that it was probably it wasn't welcomed at all. And really, the care staff there were the very embodiment of lean thinking. So when staff are faced with the situation of having to privilege the needs of one resident over the needs of another resident who, say, requires help to use the toilet, what they're actually weighing up is a whole lot of factors. So if you can imagine you're the staff member in the room showering one resident, knowing that another resident needs to go to the toilet. So they're thinking through, okay, they're thinking of the person's physical dependence, how much help they might need, whether they can give that care on their own or whether they'll need another staff member, how much time it's going to take them and what resources they need. Do they need another staff member and a lifting machine? It can take half an hour to transport a resident to the toilet when they need a lifting machine. And in terms of resources, they're probably also thinking how many other staff are around to watch over the other residents. How safe is it for them and for the resident? Are they likely to get hurt? Is the resident likely to fall? How far is the toilet? What is the likelihood that if I get them to the toilet that they're going to void? Am I going to be able to get them there in time? What's the likely outcome? And what does the resident and their family want? Is this important to them? What does it say in the care plan? And most importantly, who else needs me at this point in time? So whilst we have a tendency in our discipline to blame the person who delivers or doesn't deliver the toileting assistance, what Tina will argue is that it's actually the unethical structural conditions that cause staff to engage in compromised decision-making and compromised care. In fact, she suggests, and I'm not going to steal her thunder, but that our ability to respond caringly to the needs of older adults with continence care needs involves tackling the socioeconomic structures that shape the possibilities of ethical interaction in care. But more of that later. The second main ethical challenge for staff in providing continence care relates to the transgressive nature of the work. Continence care is intimate care by nature. It transgresses social norms about touch. And even if staff have highly developed skills, continence care practices can trigger distress and a combative response, particularly if the care recipient doesn't understand the nature of the care. So caregivers who provide this care need highly developed skills to firstly respond to the care-dependent person's emotions and behaviours, and to negotiate boundaries. And if there's any discordance between residents and staff about the care and about how it's delivered, this can escalate into coercive care, violations to the resident's dignity, and increased risk of harm not just to the resident but also to the staff member. And this transcript may resonate with some of you. The staff member said, "We have a new man at the moment and he'll just not wear pads at all. I think it's a bit of a cultural thing and he's lost his independence, a lot of independence. But I think the staff are worried because he's in a wheelchair if he's incontinent of faeces. So that is why they wanted to put a pad on him. He doesn't want to wear a pad. Leave the man. I mean, I heard him screaming. If he doesn't want to have the pad, leave him." So what she's actually describing is a situation where staff are forcing a resident to wear a pad, and it looks like the resident is in fact continent, or at least believes he's continent, but there's clearly discordance between the staff members and their beliefs about what's good continence care and what the resident themselves believes they need. These conflicts about continence care are part of nursing home staff members' everyday experience, and they accept them as part of their role. And of course, some staff manage these continence care interactions better than others, and you will have seen this. You will have seen skilled continence care interactions where staff engage in small talk, they work as a team, or they communicate therapeutically, or they anticipate the resident's needs. You can see them encouraging the resident, you can see them giving prompts and gentle nudges, or guiding them, a little bit like the girl in this picture here, just gentle, supportive, slow care. Almost like a horse whisperer, I guess. But then there's unskilled interactions that you might have seen as well that are characterised by overriding a resident's resistance, withholding or delaying care, i.e. not responding to the buzzer, or restricting their access to toileting assistance or to incontinence products, or rationing them. And that brings me to chastisement. I have a beautiful example here of what a staff member told me that she said to a resident. And this was a beautiful staff member who had experience of many years working in the facility. But she said, we had a resident and she's doing it, incontinence, everywhere. And I said, oh, no, not again. Well, what did you do? But they have dementia. And when I asked, do you know what a toilet is? And she says, of course, I know what a toilet is. Okay, but you did it on the floor. And of course, the resident says, I didn't do it. She did it, because the first thing is, I didn't do it. Another lady did it. I said, sorry, it's in your pants. It's your underwear. You are wet. So what we have here is a staff member confronting the resident and trying to get her to admit to being incontinent, to admit that the incontinence is hers. Why somebody would resort to chastising a resident for being incontinent is, we could really have a red wine conversation about this if we were together. But one theory is that it could relate to the way that we learn about bladder control as children. Because as children, it's a learned skill, and it's often, particularly in the past, it was accompanied with reward and punishment. And until quite recently, incontinence was actually considered a mental health disorder. And some early research that I looked at to improve incontinence in adults with dementia involved behavioural strategies that involved punishing them and rewarding them. It was kind of interesting because one of the rewards was that people could go to the church, and the punishment was to take the cigarettes off them. So there's the perception that incontinence is a behavioural disorder, and there are a couple of studies around that show that I think it was about 45% of staff who were surveyed believed that people were incontinent on purpose. So it suggests that we actually have a really long way to go to educate the public and the workforce about the causes and also about the impact of incontinence. So my fourth point is that incontinence is stigmatised work, and incontinence is a stigmatised condition, and nurses and care workers are stigmatised by association. It is aesthetically unpleasant, unclean, hidden work. And these quotes from participants in some of my research illustrate the stigmatising nature of care work and continence care work in particular. Some nurses and care workers internalise that stigma, and as suggested by the comment, we just do the wheeze and poos, or we just do the dirty work, is what somebody said to me. And the stigma is also evident in this comment from a daughter of a nursing home staff member when she returned from work. The participant described her daughter's horror when she attempted to prepare the family meal. The daughter said, "Don't you go making dinner, not after touching what you've been touching." And then, of course, there's the comment that many nurses get when they divulge that they're a nurse. "I don't know how you do what you do." And whilst this comment could pertain to many issues, such as, I don't know how you save lives, what staff or participants in my study interpret that to mean is, I don't know how you deal with other people's incontinence and other people's body care needs. So there's a kind of sense of horror and disgust that care workers experience. And certainly that's been very evident during the COVID period. So what could we learn from the social sciences? We learn that nurses and care workers' occupational exposure to incontinence contributes to their low social occupational status and the status of care work in nursing homes. And continence care is a symbolic marker for inequalities within the facility, the nursing profession, and society at large. It's no social accident that people who do the dirty work have the lowest social value. In fact, there's a political scientist Tina introduced me to called Professor Joan Tronto from the University of Minnesota, and she claimed one of the main ways in which societies are able to distinguish amongst castes is by the kind of caring work that people do. The devalued work of dealing with pollution is, in most cultures, reserved for the least socially appreciated, and care work is distributed along lines of caste, class, gender, and race. Nurses and care workers in nursing homes are certainly not immune to social beliefs about the unclean nature of their work. They have to find ways to deal with it. And so in my grounded theory study, I examined how nursing staff dealt with the basic social problem of constraints to care, and found that staff's affective and behavioural responses are characterised by accommodating the context, dissociating themselves, distancing themselves, and attempting to elevate their role status. And this quote is an example of maintaining emotional distance from feelings of disgust when handling residents' urine or faeces or other bodily matters. Take yourself away from it. Don't think that's disgusting, and don't say that it's gross. Say that it's natural. And yet when asked if they have a sense of disgust, they say no. So there's a lot of mind games that have to go on for staff to be able to manage the caregiving encounters related to continence. Stigma and ageism are insidious and damaging to positive caregiving. If we acknowledge and address the stigma surrounding incontinence, we'll be better placed to support positive caregiving, and would be better placed to help people with incontinence to overcome the shame and that they feel about it. I'd love to see the day when helping a patient or a nursing home resident reject the stigma of incontinence is just as important as a behavioural intervention such as pelvic floor exercises, helping them to live with it. And now I'm going to hand over to Tina.
Actually, before we go to the next slide in my presentation, there is a comment in the chat by Shona McLeod. I think Joan could respond to this at this point. She points that I firmly believe that for men in nursing homes, a sheath should be trialed first and foremost before trying to make a man wear a pad. In my experience, staff only think about pads and cannot seem to overcome this. Pads have become the norm, in probably particularly in nursing homes, but also elsewhere. Would you like to reflect on that, Joan, a little bit? What do you think of like the use of different continence technologies in nursing homes?
I'm all for technologies and interventions that are minimally intrusive and invasive and that people can manage optimally themselves. So, if a male resident can apply the sheath themselves, that would be ideal. If they have to rely on a staff member to do that for them, then there's some issues around, ensuring consent and that he's comfortable for staff to do that staff are skilled in doing it. I don't think it's an either or, so there's probably a situation where both are suitable. But it would come down to
Do you know if they use them in nursing homes in Australia? Because as far as I recall, I wouldn't be able to tell for sure, but I have a feeling that pads really are the norm in nursing homes in Finland.
Yeah.
And often the pads actually are not really the size of the pads, and their absorbance is probably not even properly tailored for each recipient, which makes them uncomfortable, and they might not hold and all that. But what about the use of sheets, for instance, in Australian care homes?
There's research that suggests 90% of nursing home residents use pads, wear pads, whether they need them or not. We don't actually have research that tells us if they're being distributed correctly, appropriately. I don't know of any data about rates of sheath use, like external urinary drainage is another name for it. It's not to say that it's not used, it's just that there's no public data about it.
I've never seen the same, and I think that could be something that we could look into in our PAD project, for instance, because sometimes residents might find better options from other technologies as well. And thank you for the question, Shona. I think it's a really, really good point, an interesting thing to consider for all of us, also in the audience. Yeah, but anyway, I'm going to take over now, and one of our shared slides, I want to say a few more words about the continence caregiving as gendered, racialized, and classed work. Joan already mentioned a lot of the issues what are at stake, and it's always been the case that working with human leakages has always been the work of those who are kind of lowest down in the sort of chains of privileges and class and so on. And it's also always been women's work, whether it is about babies or whether it is about adults. It tends to be women's work across societies, and that is one of the reasons that it's considered feminized work. Continence care is also intersectionally gendered. That means that it's not only women's work and not all women's work, but there are questions of class, race, ethnicity coming in. So particularly in the lower echelons of care professions, and that also has obviously global ethical dimensions. So whereas we in the richer countries are utilizing migrant labor to provide care for our closed ones, that means that there is a care deficient left in, and also professional nursing deficient left in a whole variety of countries in the world, which has an impact on entire health systems. So these are also questions that need to be considered. But as for the gender aspect, it is mainly women's work, and often also the work of ethnic or racialized minorities has always been the work of lower classes. But then also most people with incontinence are women in different age groups. And also, for instance, when you talk about nursing homes, most of the residents are women. So that also adds another gendered layer in the work. And then at the same time, we need to remember that men too have a gender. And then there are people who do not identify either as men or women. So incontinence with these different groups is also, when it's considered, for instance, the empirical example Joan gave about the man who refused to wear the pad. We all know that because wearing a pad is considered a feminized thing and leaking is considered feminized, then for masculine subject, it's all the more stigmatized to be incontinent. And that same applies to people at older age. And thirdly, about the gendered continence caregiving, and this is something that I want to talk a little bit more about in my presentation. When it comes to our understanding of what counts as knowledge when it comes to incontinence and incontinence care, that basic caring knowledge of providing the intimate care and working on other people's bodies, the knowledge that you gain from those experiences is considered as feminine ways of knowledge. It is something that comes out naturally. It really doesn't have to be paid for that much because, it's not really even a skill, is it? Yeah, I don't really mean that. Whereas, as opposed to masculine forms of knowledge, which are clinical, which are considered objective, scientific, and so on and so on. So there are also these kind of gendered hierarchies of knowing that are at place when we talk about continence caregiving for people who live in nursing homes and particularly on the intimate part of the labor. And then this, I think it has a lot to do with knowledge societies such as ICS and with all of us. So how do we rate this kind of caring knowledge vis-a-vis evidence-based biomedical knowledge? What counts more when we make decisions like what counts as good care and what should be how things should be done? And this is something I want to talk about in my own presentation now. So let's share screen. Yes, and there, and here. Hold on. Yes, I'm trying to, there. Yes. Oh, and let's go to the beginning. Apologies for this. Before I start my presentation, I'm going to have to say a little bit more about my background and why I'm actually giving this talk. As opposed to Joan, I'm not a long-standing member of International Continence Society. I'm a rather newcomer in this field and an odd one on the field as well, I suppose. My background is in, my background is in transdisciplinary social sciences. So I'm trained originally in international politics and peace and conflict research. So I've started from studying states and why they go to war and why people are bad to each other and how we could live together peacefully. But then I also have done, through my research and through the particular phenomena that I've studied, I've also done migration studies, social policy, particularly in old age care, global political economy, medical and health sociology, gender studies, and ethics of care. So at the moment, I don't actually really have a discipline, so to speak. So I'm just a transdisciplinary social scientist trying to understand the world of incontinence. So I'm presently based in health sciences and global health and social policy in Tampere University. That said, I also need to emphasize that I'm not a nurse myself. So you guys in the audience, you have a lot more experience and expertise of many of the things that I'm about to talk about. But I have studied nursing sort of kind of as an outsider, and nursing practices and nursing politics from various different perspectives for about 10 years now. So that's where my experience is. So I'm kind of researcher of nurses while I'm not a nurse. And this is the cover of my PhD thesis from 2017, where I studied the migration of Filipino nurses to aging Finland and the ethics of whole this phenomena from the perspective of the older Finns themselves, as well as from the nurses who migrate, as well as from the perspective of the health system and global ethics. In my present research, which you will find more about on website PAT Project online, I develop socially, economically, and ecologically sustainable continence care for different societies with different stakeholders. So I look at particularly at the production and usage and disposal of the adult incontinence pad and trying to find ways of making continence care more equal to people who need the pads, who live with incontinence, more economically sustainable as well as ecologically sustainable. On the website, there are also a couple of episodes of a podcast that I produce. It's called Pad Leaks. I have a couple of episodes waiting, I think, as well, but I haven't had time to edit them. But also, I want to emphasize that if any of you want to get involved with the project, please do get in touch. It's really supposed to be a collaborative knowledge production. But that said, it is because of this new project of mine, and this is a field where I think there will be so much work for the rest of my life, really. But with this new project, I've then entered International Continence Society, both I'm kind of both inside and outside the society, in the sense that I am a really proud International Continence Society member. It's been really amazing to get involved with these and all these transdisciplinary networks that you find in the society. And there I go with the title health systems researcher. But then partly International Continence Society, as a producer of knowledge of continence and incontinence and best practices of continence care, is partly also my object of study. Its practices and interactions exemplify a really amazing interdisciplinary knowledge production and collaboration across health disciplines and professions. I've put the health disciplines there in brackets because it tends to be really a health and medicine-based interdisciplinary, but at the same time, it is such a wide, the amount of disciplines that you can find there is, I think, it's a wonderful example of things that how knowledge can be produced collaboratively. At the same time, because there are so many different disciplines and so many different knowledge bases and practices on which the knowledge are based, there are also hierarchies and tensions of knowledge that I've observed. And one observation, obviously, is that there is that social scientific and particularly qualitative understanding of incontinence is rather marginalized in this field. And this is one of the reasons that I'm just so really quite thrilled that we can be giving this talk at the moment, and kind of also getting feedback on how and why these qualitative knowledges could be included in the society and its knowledge production. But when it comes to the hierarchies and tensions of knowledge in ICS and more widely in professional communities that provide continence care, what does this mean? So, knowing incontinence is not, we all know that it's not a simple task. There are definitely facts, yet it is such a complex issue. It's such a complex health problem that we often need to choose which facts and aims to prioritize when we want to provide the best possible care to the patient or the care recipient. Is it care or cure? Is it conservative treatments or medication or surgery? How much self-management can we ask from different patient groups? Independence and choice versus dignified dependence on care. There is a lot in all kinds of health policies. There is a lot of emphasis on the patient's choice, or some people talk about the customers in care markets, and they need to be able to choose the services. But when we talk about people who live with dementia, for instance, choice means quite different things. Can we ask them to make choices on the markets? How do we negotiate the choices, and who do we negotiate the choices with? These are really crucial questions. So I would like to bring into the table the understanding, and I think this is an understanding that ICS already follows, that incontinence is not just one thing. It has multiple realities. The medical anthropologist Anne-Marie Moll has written in her book, The Body Multiple, that the body in healthcare has multiple realities. And if you think about incontinence in any one body, in any one person who lives with incontinence, it is true that it really has a lot of different realities. There is the lived reality of that person who lives with incontinence, which is quite a different reality from, say, the urologist or gynecologist who's looking at particular options of curing the person, compared to a nurse who provides continence care and aims to help the person live with the incontinence in a way that in life that is good life. And these multiple realities of incontinence emerge from different medical and health practices. So, for instance, nursing practices produces very different kinds of knowledge from surgical practices. These are, as we do appreciate in International Continence Society, for instance, these knowledges are not competitive. They are sort of complementary often. They both produce valuable, reliable, viable knowledge on incontinence, only from different perspectives, deriving from different realities that are being observed in those particular professions, right? But then, when we decide what is the best possible care or cure for the person, we need to ask whose realities and knowledges are prioritized. Regardless of the response, whether it is the nursing knowledge or whether it is the knowledge of the surgeon, there are tensions. We all know that there are tensions between different kinds of professional knowledges in healthcare when it comes to continence care. And this is not a critique. I don't want to. This is a good thing. It's not a bad thing that there are tensions. It's quite obvious that there are tensions when you try and fit in and put kind of combine the puzzle of all kinds of best practices for this care recipient who lives in continence in various different ways through their bodies. So, and the good thing about these tensions is that when we start negotiating the tensions, when we start to create shared languages on what kind of practices are the best type of care, when we start resolving the conflicts over knowledge, this can lead to completely new and more holistic understandings of incontinence. And you probably know this much better than me, for instance, when you have a really good multidisciplinary care team providing continence care to different patient groups, and how bringing all the professional knowledge together can provide the best possible outcomes for the patient. But then we need to ask whose knowledge counts in the development of continence care practices and policies for older adults. Urologists and urogynecologists, maybe, geriatricians, geriatric nurses, continence nurses, physiotherapists, continence technology experts and the industry, pharmaceutical industry, academics, administrations in hospitals and care homes, policymakers. All these knowledges count, and they need to be counted in. But what we also need to ask is whose knowledges are at present simply not heard or listened to when we think about the best possible care for older adults living in nursing homes, for instance. And this is a sculpture, by the way, made by Eve Shepherd, a British artist. It's called The Dignified. But yeah, whose knowledges are not heard or listened to, it's often the care recipients themselves, as well as the nurses and the carers who provide the everyday intimate continence care for vulnerable older adults living in nursing homes or dependent on continence care in their own homes. So where is this knowledge? If we think about our, if we want to learn about that, where is it? And where is the knowledge of the vulnerable older adults themselves who depend on this care? And what can we learn from such knowledges and where? And this is where I suggest that there could be a much bigger role in qualitative research when we learn about incontinence, not only for older adults, but obviously to other patient groups as well. But this suggestion is obviously comes also from a person who is a qualitative social scientist, so there is a bit of a bias there. But I hope I will give you some examples now what we could possibly learn from this kind of research. And Joan has already provided several wonderful examples from her own research as well. Okay, so what I'm going to do now, I'm going to give you an example from my previous postdoctoral project. It was part of an Academy of Finland funded project that looked at mundane practices of peace in different parts of Finnish society. And one of the sites was a nursing home in Finland. I previously spoke about different providers of care. So this was a small for-profit care home. And I do want to emphasize that while we have said different things about mismanagement in care homes and bad care, I do want to emphasize that there are also a whole range of really wonderful care homes across the world where really good care and dignified care is provided. It doesn't mean that whether they are private providers or public providers that this will make a difference. Often the difference is made through adequate staffing, but also on the level of management and different kinds of sort of things that happen in the home. But yes, this is so ethnography is a qualitative research method that relies on sort of in-depth participant observation. So what I did in the care home in 2017 and 2019, 2017 to 2018, I participated in the life in a particular care home. I helped the nurses in those tasks that I could provide help in. And I spent time with the residents and then wrote down notes, what I saw and what I observed. And then discussed all these things with the nurses, as well as the residents who work there, who are part of this community. So as a result of this study, I came up with the notion caring self-protection in intimate continence care. Caring self-protection involves skills that are necessary when providing transgressive care to aggressive care recipients. So when you provide care to a person who lives with dementia, they might not always understand who you are and what you're doing to them, and often to the intimate parts of your body, of their bodies, and so on. And there can be aggressive behavior that can be hurtful. Nurses can be hit, kicked, scratched. There can be different kinds of slurs thrown at them, all kinds of both physical and verbal violence that the nurses can face when they provide continence care to the care recipients. This is not the fault of the care recipients, it is the disease that makes it, but it is part of the everyday life of intimate continence care. Okay, so what I'm going to do now is I'm going to, term caring self-protection is my term. I came up with the term, but the skills that I observed and the part of their analysis are the nurses. So, but when I spoke about these skills to them, that, oh, you did that there, and where did you learn it? They would say, oh, I didn't learn it, nobody taught me. So these are also things that they learn on the job. And I want to suggest that we should be teaching these kinds of skills and we should be learning from them. I'm going to read two extracts from book chapter that I've written about this data. These are my field notes. Today was the day of showering for Maya, a resident known for aggressive behavior during intimate care. As the nurses put on the plastic aprons and the white rubber boots, which they used to keep dry when showering the residents in their ensuite bathrooms, I asked them whether they felt anxious going to Maya's room, because Maya is known for aggressive behavior. Kirsti replied to me that yes, always, since you never really know what comes next, referring to Maya's aggression, which tend to erupt in an instant. What we know is that it is unpredictable, since those living with dementia live in an instant, as do their joys and aggressions. And the nurses, they live with it, skillfully so. As we reach Maya's room, the nurses gently wake up Maya, calling her name, calling her beautiful, introducing themselves by name. They walk to the ensuite bathroom, Maya using her walker. She usually sits in a wheelchair, so this assisted trip to the bathroom alone is tedious. Maya, drowsy still, paces peacefully, however, step by step, without resistance. In the bathroom, with Maya still standing, the nurses remove a large incontinence pad full of feces from her and assist her to sit on the toilet. Kirsti comes back to the bathroom to fetch chocolate, which the staff call magic chocolate. The sweet treat in an aggressive resident's mouth has a calming effect, giving their senses something positive to dwell upon. With magic chocolate in her mouth, Maya sits on the toilet. The nurses guide her to grab the bar on the wall, installed to provide support for the semi-mobile resident. Maya, please grab the bar for us. Maya, please do not hit us. At this point, Petra closes the door to the bathroom and I lose my view. But at this point, Maya's aggressions have started to rise. I hear Maya's resistance start. The nurse is talking to Maya in ways that seek to calm Maya down. I don't hear Maya speak. Kirsti talks to her in a friendly tone, repeatedly having to say, Maya, please don't hit us. We are only doing you good. Maya, we're only doing our work. Maya, now I must hold your hands. Maya, please do not try to hit us. Maya, we're only doing you good. Maya changes her mode of resistance. Maya, please do not bite us. Maya, you are not allowed to bite. Maya, please, can you lift yourself up a little bit? We do need to wash you there carefully so you don't get infections. Maya, please, this is about taking care of your hygiene. Here, between women, we take care of this now. I understand that they are washing the genital areas. And then the washing is almost over. And then another nurse, Petra, notices that there is another poo coming. And then Kirsti, the nurse, comments, well, wipe me must then, quite laconically. I take Maya's wheelchair to the bathroom door, moving her walker out of the way. With the door ajar now, I see Maya sitting on the toilet again, her orange cotton nightie halfway up the back. Kirsti stands in front of Maya, directing her hand to grab the bar on the wall. Petra stands next to them, ready to wipe. They fail to lift Maya's body upwards from the toilet so they could reach to the bottom properly. They ask me to help. I step in, asking for advice for how to lift. I stand to the left of Maya, put my left hand below her armpit while supporting her from the back with the right hand. I try to caress her back gently with this hand, calm her down, wondering whether I'm doing it right. We count to 3, and on the 3rd, we lift. Petra doesn't lift, but she supports Maya from the back. She manages to wipe Maya's bottom once with the moist disposable washcloth, after which she reaches beside me to put the soiled glove in the bin. I notice myself worrying that I get excrement in my clothes. Petra takes a fresh washcloth, wipes again, reaches beside me to put the dirty glove in the bin, and repeats this as many times as it takes to have Maya cleaned up. I caress Maya on the shoulder. Mimicking Kirsti from the episode of showering, I tell her that we're almost done now, almost there. Maya looks at me, deep in the eye, as if smiling a tiny bit. I glance at her free hand and see the fist, a tight, hard bundle of fingers ready to swing. I realized that I would have no idea how to protect myself from a hit, and how to protect Maya, and how to protect the nurses around her while protecting my own body if she would hit me. At the end, we assist Maya to the wheelchair. I step outside the bathroom and I hear Kirsti talking to Maya while helping her to get ready for breakfast. Maya, who, you ask? You are Maya. Your name is Maya. So this was just an example of how there you can pick up things that probably shouldn't be done at this point. If the person doesn't know her name, maybe repeating that often and again might not be always helpful. But this was just one of the episodes that I followed. And in many of such situations, the nurses, they would have a whole range of techniques and tactics that they would use to protect themselves against the aggressive resident's violence, while simultaneously protecting the client, while at the same time providing good care. So the difference here is, when I ask, like, where did you learn these skills? They would say, oh, I wasn't taught them anywhere. Well, we sometimes talk about self-defense in the nursing school, and they said that if you have an aggressive client, you just call the security and go away. But that is not something you can do when you provide intimate continence care, because if you leave that person unwashed, that's violence too. That is neglect of their care needs. So caring self-protection is a 3-pronged tactic and technique that carers utilize every day. Every day they do that to protect themselves from the aggression of the care recipient that they are from the violence that they are exposed to while providing transgressive care, while they simultaneously ensure that they do not hurt the care recipient when protecting themselves. So, for instance, you can't grab the wrist very hard because that will hurt the person. And thirdly, they make sure that good continence care is provided nevertheless. Obviously, not always such skills are used. Obviously, this can sometimes also cause harm to the client. And these are really, really difficult situations, but it's not always the fault of the nurse. It sometimes can be the fault that there isn't enough time to provide best care, or they are not taught to provide, they're not taught these kinds of skills. So caring self-protection, they are complex skills that require the nurses adjust their practice of care to the realities and knowledges of the care recipient. So when I ask the question, like, where is this knowledge that we could learn from the vulnerable older adults themselves? People who provide continence care every day actually know quite a bit about these realities and knowledges. They try and adjust the care in ways that the person who is receiving the care is heard, even in situations when they no longer know their names, or they might not even be able to speak. And sometimes, of course, their knowledges might seem irrational, but to provide good care, you need to adjust your reality to the person who is receiving the care. So I read those extracts also to the nurses themselves, and then we had a focus group discussion, and I asked, like, well, does it make sense, and is this a good term to use? And they were really happy with I think I used the term as self-defense at that point, but I think it's more about protection than defending yourself. But anyway, they were really happy with the opportunity to verbalize these skills, and also quite shocked that they were not taught these kinds of skills at school. And I had, in this focus group discussion, I asked them to verbalize the skills, like, what are the kinds of things that you do? The text now is really quite small in the presentation, so I'm just going to read out these things. And this, I need to know that this is only a really small study, and there much more research needs to go into these kinds of skills, and we need to start teaching these kinds of skills to people who provide continence care to older adults who live with dementia. So when caring for a client known for aggressive behavior, prepare yourself to the situation in advance. So these are the skills this is what they do in that particular nursing group. They prepare themselves to the situation in advance. This may mean managing your fears so the client doesn't sense your anxiety. You need to understand the lived reality that the client occupies. What do they sense in the situation and why? Adjust your verbal and non-verbal communication as well as the care practices to meet that reality. Account for the entire sensual experience of the situation. If they no longer can speak, for instance, if they no longer understand verbal communication, all these other senses are all the more important. So does the room echo? Can something be done about the acoustics? Do reflections from the mirror appear threatening? Can these mirrors be covered? Is the room cold or too warm? Would music or singing help? Can something be done about the smells or taste of the situation? For instance, putting that piece of chocolate in the client's mouth. Pay attention how you touch the client and how they sense it. For instance, an intricate modification in the position of your thumb may change the touch on the care recipient's shoulder from threatening to caring. The thumb evenly pressed next to the other fingers may feel gentle, whereas if the thumb is separated from the other fingers, it may feel as if somebody's grabbing the shoulder in a threatening manner. But of course, for other people, it might be just the other way around. So you actually need to know your care recipient. Work in pairs when necessary, but provide the main responsibility for speaking to one carer only. This provides the care recipient space to participate in the interaction rather than just being worked upon by a team of people. So when issues of personal chemistry occur between the carers and the care recipient, perhaps change the person who is doing the speaking. Consider what kind of verbal and non-verbal communication best suits the personality of this particular client in situations of aggression. Is it jokes or humor for this particular person, or rather more professional biomedical language? Or is it just stepping back silently while letting them get their aggression out? Adjust the tone of your voice and speed of speaking to the resident's individual personality, class, and background. This is particularly important when they no longer understand the words being spoken. If the client has no words to express their frustration, you may try and verbalize their anxiety while giving it adequate time to develop and pass. Pay attention how the client senses your presence. For instance, standing next to and above the person sitting on the toilet may appear really dominant, whereas squatting so that the carer's face is on an even level with that of the care recipient may appear friendly. Use clothing innovatively. If the client is likely to scratch you, you may cover their hands with soft mittens. Or if the care recipient is very reserved, it may help to partly cover them with towels while showering, so the person doesn't feel naked and exposed. So here are some of the key points to take home, but one of the maybe the most important one is that the knowledges of carers and care recipient must be accounted for in expert knowledges of incontinence, and learning from these everyday continence care practices really matter, even though they appear too messy and complex to be included in quantitative research settings. So mixed methods and using like different kinds of methods to learn about these skills and these kinds of environments is truly important. And now back over to Joan. I think we're doing really badly with time.
Thank you, Tina. Just fabulous, absolutely fabulous. I don't know how I can follow from that. Let me see if I can bring up my presentation again. Can you see the full screen?
Yes, yes.
Okay, success. So, given what Tina has just presented, and given the context that I presented earlier, I think there's some really important questions for us, those of us who work in this area and who want to improve the quality of care, around what education really is required, in order to deliver quality continence care. And our lovely colleague and friend, why have I moved on? Sorry, just a moment. Professor Chris Norton made the point some years ago that, in fact, nursing texts provide very little advice to us about how to provide continence care. They certainly don't mention anything about these things that Tina and I have been talking about here. And really, they address issues related to the use of incontinence products, which is important, but they certainly don't cover any of this. They give no guidance other than outlining the practicalities of changing the person's continence products. But it's even worse than that, because in this whole area, there's a complete lack of transparency about the nature or the complexity of the care work, which should be obvious to you now after having listened to Tina talk about the case of Maya. So accounts of this type of care work tend to downplay the bodily aspects, emphasising instead the social, emotional and personal aspects of the body. In fact, you could even argue that until COVID-19 shone a light on the issues of caregiving in nursing homes, that care work was not only downplayed, but it's been rendered invisible. And not only has the care work been rendered invisible, but so too have the care workers who deliver that care. This year, my colleagues and I completed a systematic review because we wanted to answer the question of the effects of education about urinary incontinence on nurses and nursing assistants' knowledge, attitudes, continence care practices, and patient outcomes. We found 19 studies that met the criteria, and we looked at the educational interventions themselves and unpacked what they were. And most education programs, as you can imagine, focus on the anatomy and physiology of the bladder and the bowel, the types and causes of incontinence, and behavioural interventions. The implicit goal in the education is to equip nurses and nursing assistants with knowledge to implement care that would minimise or resolve incontinence. But if Tina and I are on track about the context of nursing home care, then I think we have an opportunity, and we really do need to rethink about what education nursing home staff require to deliver quality continence care, and to question what we believe is quality continence care, particularly quality continence nursing care. And to me, it would mean that we'd start to develop educational interventions that support staff to engage in ethical decisions about continence care. And this education could draw on research conducted by Telly et al. From the US, which suggests that staff could use 4 ethical principles of autonomy, non-maleficence, beneficence, and justice in order to identify, analyse, and resolve ethical problems related to continence care. It would mean that education would be about strategies to help staff to honour the person's choice and manage risk. And I've recently come across work by Lisa Behrens in the States, who's developed a process to help staff to engage in decision-making with residents and to support them with this choice while negotiating risk. And then, of course, we could also have education based on the research conducted by Wilk et al. In Sweden, who developed a person-centred approach to continence care that involves engaging residents in a narrative to elicit their goals, their values and preferences. And really, the future education could accommodate dementia, and it could optimise safety. It could focus on communication interventions and sorts of techniques that Tina described in the story about Maya. And it could also be education about continence care that's responsive to differences not only between residents but within a resident as a resident changes and their health changes over time, taking into account the huge diversity of residents in nursing homes, the residents who might respond to preventative continence care and also accommodating end-of-life continence care. And so there's several ways of us understanding what good continence care is in nursing homes. We envisage a future in which continence care is guided by residents' choice, their lived reality and dignity. Making this happen, of course, will require structural change, educational change, policy change, and practice change. But more importantly, it would require intentional efforts to tackle ageism stigma and courtesy stigma. And I think those of you who are in leadership positions have a real opportunity here to reframe the so-called dirty work of continence care to dignity work, and to raise the profile of care workers to that of protectors of residents' dignity. And to support you in this work, this recent concept analysis that my colleagues and I completed articulates what dignity protective care looks like in practice. And so these are the individual attributes, but we also identified environmental attributes of dignity protective care. And what was important here was time to deliver care and flexible work practices, staff knowledge and beliefs about incontinence, an adequate number of staff, as well as staff who were trained, managerial support and leadership, a predictable environment, and regulation that does not constrain caring practices. And we probably have very limited time. We're a little bit over time, but one of the things that Tina and I have been debating a bit is about the strengths and limitations of choice and dignity as being guiding principles for continence care in nursing homes. And I've done some work recently that's resulted in a draft best practice model of continence care for nursing homes in Australia. And so we've had to grapple with this question of what do we really mean by best practice? And so grappling with whether it should be a best practice model that's underpinned by privileging the resident's choice. And if we do that, what does that look like and how do we make that happen? Or if it's dignity, that should be the overarching principle that guides practice. And on that point, I might invite Tina to come in because she's got some really interesting things to say about choice.
Yeah, I think it's the term dignity work that you've been promoting. I think it's hugely important, and I have some issues with the term choice when it comes to caring for people who live with dementia. And this comes partly from the fact that whenever you develop health policy these days, I don't know if this is the same thing in other countries, but at least in Finland, if you look at the development of health policies and the structures in which health and social care services are being provided and how they should be provided, there is more and more emphasis on the patient's choice, and not only the patient's or care recipient's choice, but the customer's choice. So we are no longer citizens eligible to adequate care, but we have turned into customers in care markets. And that's highly problematic, not only when it comes to people who live with cognitive disabilities, but also for all of us. Because the fact is that I'm not a health professional. I don't have a medical training. How am I supposed to know what option is always the best choice for me? And somehow, as a choice-making customer on care markets, I'm supposed to be knowing that. I'm supposed to be choosing the best providers, and that simply doesn't quite work in the field of healthcare, because often when I'm in need of healthcare service, I'm quite weak. I'm actually quite dependent on care, and that then obviously when you live with the disease like any form of dementia, particularly with some kind of a more severe form of dementia, how are you supposed to make choices in the care markets? No, you can't do that. So then the responsibility is on the family members who might already be overburdened by different kinds of. So I'm all for us to be able to kind of choose the kind of life we want. But at the same time, when we are care dependent and sick and need other people's help, then me having to make the choice shouldn't become an obstacle for me to get the best service. And then and for me to get, so then there are risks. But then I think we also kind of maybe if we can also rethink what choice means. And that's something we have discussed a lot, which shown that when persons with dementia, they still want to make choices in the care situation. So the care providers need to listen, like what are the things that they really want? How do they want to feel in this situation? And then kind of steer that situation. But if I had to put a priority between choice and dignity, it would absolutely be dignity. If you put dignity first, then you can actually use the tool of choice also responsibly and ethically, I think.
As people say, when you've lost all else, you have your dignity.
Yeah, and then other people have to help you in that. Yeah.
There's probably a lot more we could do over that, and it'd be lovely, at ICS if we could get together face to face and really debate this a bit more. But I'm very conscious of time, and so we probably should sum up. It's been a long session. Thank you if you've stayed with us. We don't have many comments, unfortunately, but what we wanted our key take-home messages to be were these points here, that the quality of continence care in nursing homes is part of a larger problem of ageism and the quality of care overall. And if we want to improve the quality of continence care, we've got to be prepared to take on this broader problem and understand it. Care work in nursing homes is skilled work, it's demanding work, it's virtuous, undervalued, it's underpaid, gendered, racialized and classed. It's also ethically challenging work. And incontinence is stigmatized, and nurses and care workers are stigmatized by association. And the knowledges of carers and care recipients must be accounted for in expert knowledge on incontinence. We really, gone are the days when we can pretend to be the expert and, please excuse me, sit in our ivory towers and create wonderful models and expect people just to implement them. They need to be co-created. We need to learn from practice, and we need to learn. So that's this point here. Education, practice, and research should mutually inform each other. And we can learn from these everyday continence care practices. And we all know of examples of good and bad continence care. And as Tina said, we should be open to discuss the tensions and hierarchies of knowledge in professional and expert communities. And ultimately, we'd like to think that residents' choice, their lived reality and dignity should guide care, and that everything should pivot around that, the education, the practice, the structures. And we haven't even talked about pelvic floor and biofeedback and bladder training. But, there's so much in this. And so what we wanted to do with this presentation, and we're really very grateful to the ICS for giving this opportunity, was to present this unique lens and view that we bring to continence care. So I'd like to thank also Tina for her time and for sharing her knowledge with us, and hope that you can come to Melbourne next year to the ICS.
Yeah, thank you so much, Joan, for inviting me to join you in this talk, and thank you, ICS, for giving us the opportunity. And apologies that we did badly with time, and thank you for everyone who listened until the end. And do get in touch if you have any comments or questions or want to get involved in either of our research.
So, thank you.
Thank you.